Hello, everybody. We're gonna get us started because we have quite a few people on today. So I'm Katrina. I'm the Events and Finance Coordinator for British Undergrad Society of Urogynaecology, and thank you very much to everyone who's joined us this afternoon. It's our last webinar of the year, and today we're going to be talking about urogynecology, and we'll be covering urinary incontinence and urogenital fistulas. So a little bit of housekeeping before we begin. So as you probably know, a bit of Zoom etiquette. Please keep your cameras and your microphones muted because we are recording this. Also, due to some disruptions in our previous events, we will this time be only admitting people in between speakers. So if you have any friends in waiting room trying to get in, just if you could let them know that'd be great. However, if you do get kicked out, if your Wi-Fi cuts, like we have a moderator who will be kind of monitoring the participants list, and she will let you back in. So structure of the day, then we have 3 speakers, and we will have around a 20-minute presentation by each speaker, followed by Q&A right after. And as always, you can use Slido links, which will be posted in the chat, and please direct all questions within the Slido instead of the Zoom chat. And finally, we just like to thank our sponsors, the Medical Defence Union, for sponsoring this webinar. And making this happen. So one final thing is certificates. As usual, if you want a certificate, please do stay until the end, as we'll be posting a feedback link, which we would really appreciate if you fill in, because it really helps us improve our future events. And if you've got any issues with the certificate, we will be staying behind to make sure everybody gets their certificate who wants to, but we will not be sending the link or the certificate out afterwards. So without any further ado, we are going to open the floor up to our first speaker, Mr. Gans Thiagamoorthy. So Mr. Gans Thiagamoorthy is a consultant urogynaecologist who serves as the Information Committee Chair at the British Society of Urogynaecology, and having conducted research focusing on the quality of life and improving the care pathways of women, Mr. Thiagamoorthy has presented nationally and internationally, as well as being widely published in journals and textbooks. So I'm going to stop sharing. Molly, if you could let Mr. Thiagamoorthy start slides.
Lovely. Thank you for having me, Katrina. It's a great honor to be participating, and I'm pleased that you've got such a good turnout, and also you're well supported. So, is it sharing my screen currently?
It's not at the moment. Oh, yes. Yep.
Lovely. Okay, have you got the PowerPoint view in front of you?
Yes.
Lovely. Great. So, ladies and gents, I'm going to give you a little brief overview about urinary incontinence and explain what we do. So as Katrina's already said, I'm Mr Gans Thiagamoorthy. I'm a urogynae subspecialist who works in Ashford and St Peters. So that's where we work in leafy Surrey. And urogynae, just as a brief overview, not only involves urinary incontinence, but we also look at prolapse, which is herniation of the pelvic organs into the vagina, recurrent waterwork infections, bladder pain as well, overdistension injuries, which happens commonly postpartum, but also after surgery, and also can happen completely randomly, but it's something that we need to keep an eye on. And we also look into postpartum and antepartum pelvic floor problems, such as third-degree tears, or women who have incontinence or prolapse even during pregnancy. So yeah, that's generally an overview of the things that we talk about. Then, so let's move on to urinary incontinence, and we'll start with stress incontinence. So stress urinary incontinence is a symptom complex, and it's a complaint of involuntary loss of urine on effort or physical exertion or sneezing or on coughing. Whereas urodynamic stress incontinence is the diagnosis based upon filling cystometry. So basically involuntary leakage of urine during filling cystometry associated with increased intra-abdominal pressure in the absence of a detrusor contraction. So that basically means you conduct a test called urodynamics, where we assess the woman's bladder in detail by introducing pressure lines into the bladder and into the rectum and compare the results and see how things change. So if one leaks without an increased pressure in the bladder that's not in the abdomen, that's called urodynamic stress incontinence. Won't go into too much detail for that, but just to give you an idea of what that means. So traditionally, the treatment was, first of all, pelvic floor muscle therapy for a period of 3 months. And then if that doesn't work, then you'd move on to surgery. So surgery originally was the Birch Copper suspension, which is a significantly large operation. So it involves a cesarean section-like cut. And as you can see on the picture here, where the hand is outside the body, so that's the fingers in the vagina. And so if you can imagine where you're looking from the patient's almost chest area, looking down towards the pelvis here, and you can see the symphysis there. And there's a little ligament which runs along the line of the symphysis called Cooper's ligament, the iliopectineal ligament. So as you can see here on the sides, you've got the side of the bladder, the paravaginal fascia or tissue, which is being sutured up onto this Cooper's ligament. And by doing so, you're hitching up the bladder, well, the side of the paravaginal tissue, and you do it on both sides. And by doing so, you're lifting up the bladder, but also lifting up the urethra, so it's more supported. And cure rates vary, and Prof. Hilton's on today, who we speak to later, but he published an amazing paper which revolutionized the way we look at cure rates, and it just depends on what you're looking at. So cure rates can vary from satisfaction to cure with incontinence aids and so forth. The cure rates for this were good though, between 70 and 100%, but there is a side problem of possible prolapse. The more recent treatment for that, for stress incontinence thereafter, was a sling. And you may have heard about this. So mid-urethral slings or tapes or autologous fascial slings. So these slings generally are made from a mesh, a polypropylene mesh, which is the exact same material that's used in hernia repair meshes, but in just cut in a slightly different way. So this, instead of having a large operation, which takes about 3 hours, like a Birch Copper suspension, then the mid-urethral sling took about 30 to 45 minutes, and the patient could go home the same day and didn't need very much follow-up thereafter. So it became very popular in sort of 1995. The cure rates were very similar, but there was this issue of tape erosions. The concern is the tape erosion could either go into the vagina, the urethra, or into the bladder. Now, if it goes into the vagina, it wasn't causing too much of an issue, and a bit of local estrogen normally could sort that out. Worst case scenario, a very small day case-like procedure to repair the tape erosion sorted that out. However, if it eroded into the urethra or the bladder, that can cause significant problems. So we'll show you the different ways in which the tape can be put in. So these are the introducing hooks. So this is an obturator version. This is the retropubic version here with the blue bits on it, called a TVT. It was very good, but there were some problems. So that's why that's been paused. So in July 2018, we were stopped from doing that operation, and it's looking like actually we might be able to resume pretty soon. The idea was it'd be stopped for about 6 months while we reviewed the data. However, then we had Brexit, and then we've had coronavirus. So things have been, slightly more protracted than ideal. In Scotland, a few years ago, this operation was stopped as well. However, due to lobbying from patient groups, actually, who felt that their human rights were being violated because they weren't allowed to have this operation, which was very straightforward, but had a very low complication risk, they actually reinstated it. But then, about a year later, the whole British government stopped it to investigate. So we'll see where we are with that soon. The other operation, which is commonly undertaken now, is periurethral bulking. So this operation seems a nice idea. It's, if you imagine, this is the mid thing there is the urethra. You've got the top bit of pink you can see just on the top of the image there is the bladder. So we're looking at the bladder neck and the urethra. So what you're doing is closing off the urethral lumen slightly by injecting what is about 97 or 98% water. It's a polyacrylamide hydrogel. So basically, it's mostly water, but it has got some particles in it, and it basically forms this sac here, which obstructs the urethra slightly and helps improve continence. Now, the success rates aren't that great though, but again, it comes back to how one assesses cure, and cure for this is considered 60%, so that's dry really, whereas 75% of women who have this procedure are quite content. Now, there are some advantages of this procedure because it's minimally invasive, it's conducted under local anesthetic, has low real risk to the patient, low risk of voiding difficulties afterwards, and also it has low risk of de novo detrusor activity. This is where the bladder gets irritated and becomes overactive due to irritation and fibrosis around, which commonly does happen with the copper suspension or the other tape. So in this scenario, yes, it's pretty low risk. The disadvantages, however, is low efficacy, so it's less helpful than the other operations. The benefit may decrease with time, and you might need repeat procedures. I know in some women, we've had 2 or 3 operations repeated that seem to sort out well. The previous iterations of this bulking agent did have complications, as this drug called Zuidex, which used to have abscess formation and things. We're not really getting that with Bulkamid. However, there are the occasional case report of a small abscess or things out there. So, I mean, it's early days, so we'll see how things come out. And there's an issue of cost as well, because this procedure, just the materials itself, costs £800. So put on top of that the theatre time and all the rest of it, it can become quite costly, especially if you think the efficacy isn't that great. Follow-up. So after you've ever operated or treated a woman for stress incontinence, you need to make sure she's followed up. And this includes a vaginal examination to exclude erosions within 6 months to all women. Now, after you've done the conservative, which is your physiotherapy, then you do your surgical, which we've talked about. Thereafter, there's another option here called medical, and this comes after the surgical, which is unusual for how mostly we treat things. There's normally conservative, medical, surgical. That's the mantra we all learned, didn't we? So in this scenario, Duloxetine is an SNRI, so used to treat depression, and it's still used for that reason, anxiety today. But they found that actually improves incontinence episode frequency by about 60%. But it's not a first-line agent because, well, the efficacy isn't great. But in fairness, not all the drugs are that good anyway. But this does have some serious side effects, such as suicidal ideation and real bad nightmares. So, it's just not a first-line agent because there are other things which are much better. But it is out there for women who can't have surgery for some reason or just decline it. Montgomery. So Montgomery is a big issue, and I'm sure you guys, being BUSOG, are aware about this. So this is the case where the lady was pregnant and she was thought to have a reasonably large baby on board, and it was not discussed with her the risks of shoulder dystocia. So she then sued Lanarkshire NHS Trust or whatever to say, look, you should have told me this, and my child now has Erb's palsy. It went through, and initially it was turned down, and the NHS won. However, she appealed, and it came back, and actually was agreed that however low likelihood a problem may be, if it has a significant impact or the effect of it could be significant on the patient's decision-making process, one should inform them. And so that's revolutionized obstetrics slightly in the way that before it was sort of, well, a vaginal delivery is a default, and if you ask, you may be considered for a cesarean section. Now we have to view things slightly differently, where actually you've got to tell women the risks of a vaginal delivery as well, which is a good thing. And in fairness, it's probably in keeping with the GMC guidance that most of us in this day and age are probably trained with anyway. Do no harm and tell the patient as much as you can. Give them the power to autonomically decide what they want to, autonomously even, decide how they'd like to deliver. But then moving on from that, so stress and urinary incontinence surgery, post-Montgomery and the Mesh disaster. So make sure that if you are going to treat a lady with stress incontinence, do get your patient-reported outcome measures. So this is where the patient completes themselves, or the clinician will help them complete a form which states how their life is currently with regards to stress incontinence symptoms and how it's being affected. So how is their quality of life? Can they do their daily activities? Can they have sex? Can they go shopping? How is this limiting them? And how is this affecting them? And how does that make them feel? So it's really important to get the patient's perspective, because at the end of the day, most of urogynecology is not life-threatening, but is quality of life limiting. And we're here to try and improve that. So yeah, it's PROMS. Then we perform examination and conduct the relevant investigations, including urinalysis, to make sure you're not talking about UTIs here, making sure you do a flow rate and residual and maybe assess their bladder to make sure that there's no urine left behind. Then you might do urodynamics to assess the way the bladder performs and confirm this is urodynamically proven stress incontinence. Thereafter, you'll counsel them regarding all the options, be it pelvic floor muscle therapy, a stress urinary incontinence pessary. So there are certain pessaries out there which have a knob at the end, and that knob is supposed to support the urethra and reduce stress incontinence. I say supposed to because I have had very limited success trialing this, and I don't know many clinicians who feel that, oh, this always works. No, I think it might occasionally work, but it, in my experience and a few of my colleagues, doesn't really work that well. Then there's non-mesh surgery, then there's permanent meshes, and there's pause, as we've spoken about. You always got to give them leaflets and then give them time to think. So while they're thinking about this, you can take their case to the MDT. So that's the urogynecology MDT, which is now either a local or regional, depending on the complexity of the operation. And there are urogynecology surgeons like myself. There'll be urogynae specialist nurses. We have 2 in my department. Then we have urogynae specialist women's health physiotherapists. So we've got 4 in our department who participate. We also have a friendly urologist who participates and a radiologist who's involved with imaging. And we all sit together, assess the patient, assess everything we've had so far, and decide, do we think surgery is appropriate or whatever we're planning for them? And if we agree, then we can proceed. So we go back and tell the patient, yes, we discussed your case in MDT and we've all agreed this is appropriate. Or we say, actually, no, the physiotherapists feel actually you haven't really been participating with your exercises and you could do a lot better. So we might just delay your surgery a little bit further, just see if you can improve things slightly. Then we also should afterwards record the operation in a national audit database, and I am the information chair for the British Society of Urogynaecology, and I think it's really important that we submit all our data to the national database, which is voluntary at the moment, but I think that will change soon, where if we are able to submit our data, we can see across the country how these operations are performed, why they're performed, and how well the patients fare afterwards. And this will help us tell us, and at the end of every year, we can click on a button and find out, compared to the rest of us, how were we? Was I in the lowest 5%? Was I in the top 5%? Was I just happily in the middle? And I guess if we're falling below the percentile or outside quartile, maybe we need to look at ourselves and assess why is this happening. And I think in the future this will be involved in our revalidation. Then afterwards, we should also get the patient to complete a post-operative prompt to say how they're feeling now, say 6 weeks or 2 months down the line, to make sure they have had some improvement. And this helps frame the problem for them as well, because it tells the patient, oh, no, yeah, good point. I used to have this problem where, I scored 7 out of 10 for bother and, leakage was 3 times a day. But now I guess I'm now leaking once a week. The bother is much less. Yeah, okay, you know what, you're right. I forgot how it was before, but it makes sense. I am better. And then they feel happy with this. Or it might tell us our operation was absolutely useless and we need to go back to the drawing board and figure out the next step. And we need to be aware of potential long-term complications and thus have a low threshold to review patients again, and also do it with an empathetic face. Because I think one of the major complaints came back that gynecologists generally, and the problem is these operations were done by general gynecologists and not subspecialty or specific urogynecologists. And the problem was they weren't as empathetic as ideal, and the patients felt they're being fobbed off. So you need to make sure you're not giving patients that impression at all. And I know sometimes we might not aim to do so, and we might just be completely unintentional, but we just got to work really hard to make sure we don't give that impression regardless. So that's one half, stress incontinence, and the other half is ono-erected bladder. So either you're leaking urine from exertion, from straining due to a weak urethra or some support like that, or you're leaking urine or you have the urge to go to the toilet often because your bladder itself is contracting when it shouldn't do and making you wee. So this is an overactive bladder and detrusor activity. So I'll break down the two similarly like I did for stress incontinence and urodynamically proven stress incontinence. So here we've got urinary urgency. An overactive bladder is urinary urgency, usually accompanied by frequency and nocturia, with or without urgency urinary incontinence in the absence of a urinary tract infection or any other obvious cause. So again, don't forget to do a urine dip and also check a residual. Detrusor activity is the urodynamic observation characterized by involuntary detrusor contractions during the filling phase, which may be spontaneous or provoked. Okay, so hopefully that's clearer. And this is the treatment algorithm. So it starts first of all with the least invasive and works your way right up to the top to complete reconstructive surgery. So lifestyle advice and peripheral muscle training and bladder training. So bladder training lasting at least 6 weeks for the sake of overactive bladder should be offered as a first-line treatment. And that's to do with lifestyle interventions. So that's going to be bladder drills, taking long to wee, but also talking to them about fluid intake, caffeine intake. The caffeine includes tea as well. Some women sort of don't realize that, and even hot chocolate. Coke, particularly, and Coke is an interesting one because it's a cold beverage which can affect the bladder. It's fizzy because it's got carbonic acid which irritates the bladder, and it's got caffeine. And the worst of them all is Diet Coke, which everyone seems to love. And Diet Coke, because it's got the artificial sweeteners, affects the bladder even more. So artificial sweeteners, sadly, are a problem, especially in the younger population I'm seeing nowadays. We're getting a lot of young ladies in who drink a lot of G&Ts, which, you know, it's a nice enough drink. It's a great summer's drink, or even not even summer drink, to be honest. But the ladies are having it with slimline tonics. And the slimline tonic is the problem. Particularly the Schweppes one has artificial sweeteners. I've checked the Fever Tree, and the Fever Tree, she doesn't say it's got artificial sweeteners, and so it's got some random berries. So maybe it's not as bad. I guess one day we'll have to do some sort of testing, find out. Weight reduction is important because obviously the weight pushes on the bladder and means it's unable to hold as much urine as possible. So that's also an issue. Bladder retraining is an interesting one. So we've talked about training, but then physiotherapy, pelvic floor muscle therapy. And we know from evidence that the nerves which innervate the pelvic floor, S2, 3, 4, also innervate the bladder. So by squeezing your pelvic floor, you actually override the urge to go to the toilet, and that can buy you some time to make it to the toilet and not leak. So that's a clever little technique to learn. For women who are postmenopausal, and that could be due to us from surgery or premature ovarian failure in age 40 or even earlier, or just the natural age of menopause, which, as you know, is about 51 years in the UK. So we can find that the vaginal tissue might become slightly drier, thinner, and what we call atrophic. Now, part of the whole term urogenital syndrome of the menopause. Now, the base of the bladder embryonically is also formed of the same material. So that trigone can also get irritated. And so using estrogen can make things slightly better. So we know full well, and this is a nice guidance as well, that vaginal estrogen will improve OAB if there's symptoms of vaginal atrophy. So that's something to consider as well. And vaginal estrogen is fantastic. It's a supremely low dose. So it's currently used at sort of 25 micrograms twice a week. And if you consider that to normal HRT, which is at the least dose, 25 milligrams, so almost 1,000 times more than this, but it works very well. So the next line of therapy are the antimuscarinic agents. And so after lifestyle things, you use antimuscarinics, and the antimuscarinics reduce your intracycle pressure, increase compliance, that's the stretchability of the bladder, and increase your threshold volume, which you think, oh, I need to wee, and also reduce uninhibited contractions. There's been an evolution of the antimuscarinic therapies. So, started off in the 70s just with oxybutynin. Then that moved on in the 90s to a range of them. Trospium, which is an interesting one because it's meant to have a large molecular size. There's extended release oxybutynin. And then in 2010, we had more out there, including patches, gels, and even more specific ones like solifenacin, which targets more specifically the M2 and M3 receptor to hopefully give you less side effects. And as you remember, antimuscarinics have a range of side effects. And these range from dry mouth, constipation, blurred vision, excessive sleepiness. And as a result, you need to have a face-to-face or telephone review with the patients about 4 weeks after starting. Again, to be honest, in the hospital, secondary or tertiary care, I can't organize a review within 4 weeks, and even my urogynec nurses can't. So generally, there's something we pass back to the GPs to make sure they check that there is some improvement. You expect some element of improvement by about 4 weeks, and so the GPs can check this and make sure the patients are happy with this and continue or change the drugs. If there is some improvement, they should try and persevere, because most of the drug studies are showing us at 12 weeks away, you get maximum efficacy. So if you have some benefit at 4 weeks, try and continue till 12 weeks. There are other side effects though, and there's a big thing. It's called the anticholinergic burden. And so this is something that came out with a paper by Fox in 2011. I think Gray had another paper in 2013, but clearly showing us that women or people who take anticholinergics have a decrease in their mini-mental scores and have increased mortality. There's proof that increases Alzheimer's and dementia as well. Now, this is something people don't generally talk about because I think this is relatively small print data. Because if you look at the drugs, and anticholinergics anyway, but look at the drugs which are included in this. And this is a score that I quite like to use from the Aging Brain Care. It's online. It's got a score of 1, 2, 3, 3 being the worst. And if you look down the 3, you've even got things like chlorpheniramine. And chlorpheniramine is Piriton. It's what people take like Smarties all the way through various seasons, spring, summer, autumn, maybe not in winter, but if you've got some allergy, you might have a winter too. And all these drugs can increase your risk of Alzheimer's dementia significantly, but it's not really spoken about. So I think going back to what we spoke about with regard to Montgomery, I think it's important that we mention this to our patients, and I do every time. And most think, okay, doc, I'd rather not have this drug, thank you very much. But some are like, fair enough, but my symptoms are bad enough, I need it. The main thing is it's informed consent. They have to be aware and decide, and that's that. Then, so this is the mode of action for antimuscarinics. The acetylcholine is blocked, and that stops the contractions of the bladder. So activation of parasympathetic pathway causes intrusive muscle contraction and maturation. So we're trying to stop that. There's another drug out there called MIRABEGR. So this family of drugs came out in 2013. So it's a beta-3 agonist. And here we actually, when you're activating the sympathetic pathway, it inhibits detrusor contractions and contracts the bladder outlet. So that helps maintain continence. So beta-3 receptors are only found in the bladder and in brown adipose tissue. And initially, actually, this drug was created with a view to see if it helps with diabetics and diabetes. But unfortunately, it wasn't beneficial, but we found out it worked really well in rodent bladders, and thereafter continued and was proven to be used for this. As this drug came out in 2013, there have been a couple of drugs similarly, like Solobregon, which almost came to market, but didn't quite make it to phase 3 trials. But recently, I think just last year, there's a new drug called Vibegron, VI, and that looks like it's done really well in its phase 3 study. So hopefully we'll have another drug out there to add to this family as well. Like I said, it's the beta-3 agonist, and the benefit of this drug is it has the same side effect profile as placebo, which is fantastic. But again, this is interesting, and I always tell my patients, look, okay, you're selecting MIRABEGR because I'm telling you, there's no evidence to say it causes dementia and all the side effects that we found with the oxybutynin and the anticholinergics. However, we only found out about the problems with the anticholinergics. They came out in 1970s, and we found out about this in 2011 and became more mainstream. Well, it's probably not even probably mainstream yet. But we only really found out the problem almost 40 odd years after the drug came out. So similarly, MIRABEGR's been out for 8 years now. So, it's limited data out there. So, don't take this drug solely because you think it won't cause dementia. I guess you haven't been told it does cause dementia, but it could have side effects down the road that we just don't know of yet. So you just have to be aware of this problem. One thing interesting is during the large randomized studies, and these studies were conducted across the world, from Japan, America, Europe, UK, everyone who was everyone published a paper on this. When the drug studies were conducted by Astellas, one of the big firms out there, and they showed all the results, which were very positive, as good as the anticholinergics without the side effects. But intriguingly, it showed us that there were only a 2 to 3 millimeters of mercury increase in blood pressure, which, with the beta agonist, you think, okay, fair enough, but 2 to 3 millimeters of mercury, it's nothing. Forget about it. But actually, about a year after the drug was released, there was a major release from the MHRA to say, actually, there have been occasions where people on this drug have had severe uncontrolled hypertension and suffered with stroke. As a result, we need to make sure anyone on this drug does not have uncontrolled hypertension. So how do we do that? They didn't really specify, just said not suitable for anyone with uncontrolled hypertension. So by that, you can assume they've got hypertension, but it's controlled. That's okay. But then how do you know if you're going to catch uncontrolled? I guess if they have symptoms when they go see the GP, they'll know. So just to play it slightly more cautiously nowadays, I tell my patients, before you start, get your GP or your chemist to check your blood pressure, make sure it's okay, and probably get it checked monthly thereafter. At the moment, we don't want to add extra burden to our general practice colleagues, and also with COVID, you don't want your generally slightly more older patients having to traipse their way to a pharmacy and expose themselves to corona. As a result, Amazon and all good other stores out there sell blood pressure cuffs, and now you can get good blood pressure cuffs for about £20, and it automatically checks it. They record it, and I normally just say, check your first result at the local chemist with your machine and their machine, just to make sure it's all calibrated properly. As long as it's fine, then that's perfectly fine to carry on. And maybe once a year, just double check with your GP. And if you're on an anti-blood pressure tablet anyway, the GP is bound to check it for you just to make sure. But these are just things that you think of yourself just to make sure you're keeping your patients as safe as they can be without much hassle. So that was that. And then after that, there's the next line of therapy, and that includes Botox and also nerve stimulation. So we'll talk about Botox first. So Botox works by working on the nerves by denervating them basically and paralyzing the nerves from working. So by stopping the nerves working, it then stops them innervating the muscles, and the muscles then don't contract. And that's why people use it around the face or the eyes, particularly for the orbicularis muscle, to paralyze that, to stop the crow's feet. Similarly, in the bladder, as we've spoken about, it's the detrusor muscle which is contracting inappropriately. So just like in the picture there, if you have some injections into the detrusor muscle, you would hopefully then paralyze the nerves and as a result paralyze the muscle and stop it contracting too much, which is great. But the problem with that is it can actually work a little bit too well. And 4%, so 1 in 25 women who have Botox injections in the bladder will find that they're unable to enter the bladder well themselves. Now, the different papers have different levels of what they call unable to enter your bladder, and it varies from about 300 mils in the bladder, which I think is a lot. I'd consider, so if you leave more than 100 mils in your bladder, if you, like a rule of a third almost in your bladder, then I think that's too much, and that can lead to difficulty, can lead to recurrent waterwork infections, and also the sensation of frequency, because you've got more fluid in there, it fills quicker, so you need to go to the toilet more often. So I would say 100 is the figure I generally use, and so I normally teach all my women to undertake clean intermittent self-catheterization to make sure they can empty their bladder before they have the Botox, because what I don't want is to leave them and then suddenly 2 weeks later find out they've gone to urinary retention and damage their bladder. So if they can perform self-catheterization, actually, I tell them, if you have any concerns, pop a catheter in and see what's left. But if not, at about 2 week stage, pop a catheter in after you've been for a wee and see how much comes out afterwards. And then call my nurse, then talk it through with them. And that actually helps us, because that means that we don't have to see them for another appointment. They get the right treatment. And then we've got a few ladies now who just email us at around 6 to 9 months, because that's how long it generally works for, and then say, I'm starting to have some symptoms again. Do you mind if I come back? And we just put them straight back on the waiting list for another Botox. These are things I now do in the outpatient area, so it's quite easy and straightforward. The neuromodulation devices, so sacral nerve stimulation. So I told you before, squeezing your pelvic floor innervates the nerves that go to your bladder. Well, there's a way of doing this exogenously, which is by putting a sacral nerve stimulator device. You implant it into the body, and that actually, you can see that little device on the picture on the lady's back. That one has a battery which lasts about 5 years, and it's fantastic. So you do need to go back in 5 years' time to change the battery, though. But there's a newer one which just came out, I think, last year. It's all blurry now. I think maybe just before. So maybe it's maybe about January, February in 2020, which is same company. Everything's the same, except for now it's MRI compatible, and the battery point is the size of a USB, a thumb drive, which is fantastic. Its battery only lasts about a week or so. However, you wear a little belt around your waist, and it contactlessly charges, like you charge your phone these days, or your Fitbit or whatever, which is fantastic. So actually, you can sit there watching your telly, put your belt on, charge up your nerve stimulator, and crack on. They used to use this device on the right, which is, or we used to choose the different programs to improve the bladder function. And also, because the same nerves also innervate the pelvic floor, it also helps with bowel symptoms. So bowel surgeons use the same thing as well. But they've now upgraded, and they also have a phone app, because they're worried of people hacking it. You have to use their own phone that's supplied, but I'm sure in time that might change to literally just an app on your own phone. But it's fantastic. The other one is posterior PTNS, which I've got here, which is posterior tibial nerve stimulation. So you only offer that if the patient declines Botox or SNS, and this is slightly less efficacious, but is still pretty good, and is, like the periurethral bulking for stress incontinence, it's pretty minimally invasive. So the patient comes in, the physios generally, or your urogynaecologist, will see them, and they put like an acupuncture needle in the posterior tibial nerve, which runs, as I'm sure you remember, just behind the medial malleolus. They put that in. The nerve then connects to an electrical device which stimulates the nerve, and actually lasts just for 30 minutes, and that retrains your nerves, because the same nerve at the posterior tibial goes up to innervate the bladder as well. So by doing so, 12 sessions, so 12 weeks though is the drag. You have to come in for a half an hour session, and that can improve things. So that's another thing to do. That's that. So yeah, that's the main treatment algorithm. Finally, right at the top, we've got reconstructive surgery, which is the most invasive. This isn't something we do very often. Operation I've done a few times, but not many, is called an ileal conduit. So we will remove a portion of the ileum from the bowel and reconnect it with the help of a friendly surgeon. And then we remove the ureters from the bladder, reconnect it to the ileum, and then bring it out like a stone onto a stoma, onto the abdomen, and that collects the urine. So then the bladder is no longer useful, and the symptoms of detrusor overactivity are irrelevant now, because it will just collect like a catheter bag on the abdomen. But obviously it's not easy, and there's risk of parasitomal hernias, breakdowns. Sometimes, and we've had a case, I remember once a few years back, where the patient had irritation of the bladder despite the fact there was nothing coming out of the bladder. And so they went to go back and actually remove her bladder as well. But yeah, interesting case. There's another operation which I've never seen done, but I heard urologists do it. But again, I don't know anyone's actually done it yet. Maybe Paul may have himself. An augmentation cystoplasty, where you again remove a portion of the bowel, but this time put it on top of the bladder. You open the bladder and connect it together just to increase the size of the bladder, really. But that's been shown to have increased risk of bladder cancer. And I don't think it's done that often these days, but there are some who still do it. So that's it. Like I said, make sure you review the patient face-to-face or telephone, refer to MDT, and consider urodynamics if things aren't making sense, especially if they've had a previous stress incontinence operation and they develop urgency or recurrent UTIs. Make sure you urgently do a cystoscopy to look inside the bladder to make sure there's no tape or anything bad going on in the bladder or the urethra, and to exclude your tape erosions, and also do urodynamics to exclude de novo detrusor activity. Mixed urine incontinence is interesting. So here's where they've got symptoms of both stress urine incontinence and urgency urine incontinence, but you really have to find out from them which is the most bothersome symptom and try and treat that first. However, because we know full well that stress incontinence operations tend to worsen overactive bladder symptoms, it may be worth treating the OAB first, and once you've got that fully under control, then moving on to the stress incontinence, because otherwise things get a bit muddied and you don't know which one's which. But yeah, that's that. So thank you very much for listening. I don't know if you've got any questions for me, and if not, you can always email here as well.
Thank you so much, Mr. Thiagamoorthy. Yes, there are some questions, if you don't mind. So the most upvoted one is, do you think that it should be a requirement, like with other procedures, to discuss potential continence issues arising from birth with pregnant patients?
Yeah, I think it is useful. However, it's not as straightforward as we might hope or think. See, if you're wanting to discuss that with them, you're assuming that there's something they can do to reduce the risk of incontinence afterwards. Now, just carrying a pregnancy full stop will increase your risk of urinary incontinence later on in life, for regardless of which way the baby's born. We know in the short term, in the first few years after delivery, be it cesarean section or vaginal delivery, well, I'd say cesarean section first. Cesarean section, you might not get stress incontinence then, but 5, 10, 15 years down the line, you almost catch up anyway. So that's the difference. Whereas if you have vaginal delivery, yes, you're higher risk of stress incontinence almost straight away. I think the stats are 50% of women who have a baby will have either prolapse or urinary incontinence later on in life. So, they're large figures. So yeah, I think it's worth mentioning and talking to the patient about that. But you've got to give them the true picture, which is it might be better in the short term, but by in the long term, you might not improve things for incontinence. But interestingly, for women who have detrusor overactivity, but are continent, so don't have stress incontinence, but have urgency, they're the women you might consider saying, actually, go and have a cesarean section. And that's because their pelvic floor is what's maintaining their continence at the moment. So if they damage their pelvic floor by having vaginal delivery, they may develop urinary incontinence straight away. So that's something you could actually probably say, maybe it's worthwhile considering. But that's sort of outside the box thinking on that one. But there are some good data, especially from the Scandinavian countries, and Professor Milsom, who talks about your first vaginal delivery is the one that causes most of the damage. So it's something to put out there.
That's very interesting. Another question is, there's been a recent surge in pelvic floor related products like weights in shops. Are these useful, and should they be encouraged within the general population?
So yeah, this is very interesting. I think that most women who are able to contract their pelvic floor themselves do not need vaginal weights, cones, or biofeedback devices. They are an extra step which make it harder for the lady to perform a pelvic floor exercise herself. So right now, if male and female in your audience now, if you just clench your pelvic floor as much as you think it is. And the way to do it is if you think, I mean, it's slightly gross, sorry guys. I hope, well, it's a bit late now. I hope no one's having their lunch. So if you can squeeze your pelvic floor, like if you're doing a poo and you want to break your poo off, if you do that, that's how you squeeze your pelvic floor. You shouldn't be feeling your glutes bouncing up and down. You're not doing it right. But if you can just do that simple movement and pretend as if you're weeing, you're just going to try and stop yourself weeing midstream, just try that for a quick moment. If you can do that, that's what you need to do for pelvic floor. And thereafter, all you have to do is learn how to do different ones. So do a long squeeze, do a short squeeze, do a fast squeeze, and then do those 8 times in a row. That's 8 squeezes, pretty straightforward. And do that 3 times a day. Not a big deal. If you can do that yourself, and I normally tell women, build it into your daily lifestyle. So every time, most women will have a hot beverage. Every time you put the kettle on, do your pelvic floor exercises. Or if you're in the car, you see a red light, do your pelvic floor exercises. And it comes almost Pavlovian then, right? So every time you see one of those or do that, you do your pelvic floor exercises. Job done. You'll have a pelvic floor of steel. Whereas if you can't do that and you can't feel there's improvement, and that's where either seeing urogynecologists or physiotherapists who specialize in women's health will be able to examine you and see, okay, look, you have got a good squeeze, it's working well, fair enough, move on. But for those women who can't feel anything or feel a flicker at best, they may need a biofeedback device or they may need cones to help teach them how to do it. But the problem is if you're doing that, you've got to lie in bed, you've got to find a private moment. When are you going to do it? Realistically, it's unlikely. But if it gets you to that point where you find out where your pelvic floor is and how you contract it, then maybe it's worthwhile.
Mm-hmm. That was a really good explanation, actually, of how to explain to a patient what is pelvic floor exercise. So I'm sure that's going to be useful for us. And maybe novel treatments that are currently researched that you think could make a real difference to patients with stress urinary incontinence.
I'm really sorry, you cut out there on my screen for some reason.
Oh, no worries. So are there any novel treatments that are currently being researched that you think could make a real difference to patients with stress urinary incontinence?
There aren't that many at the moment. One of the good things which actually been out there for years is autologous vaginal sling, which not many of us do, but we need to retrain and learn how to do, which is where you take a sliver of the rectus sheath out and you use it just like the tension-free vaginal tape is used. So that's one thing I think a lot of us need to retrain. I remember learning how to do it, but didn't have to do it. And I'm a bit rusty now, so I need to retrain to get myself a bit more familiar with that. But novel things coming forward are, there's one thing which we've talked about for years, we haven't got yet, but it seems like we're getting a step closer. It's using stem cells. So stem cells to actually regrow the urethral sphincter muscles to try and reinforce that. So I think that's where hopefully the future will go. But the way we've gone through with the vaccines, good old Pfizer and Moderna things, you can see, gene therapy and things is coming. And we're getting there. So hopefully we'll be able to improve that soon.
And perhaps one or two more. Do you think that urinary incontinence is managed adequately in primary care? And what changes would you make if you could?
I always feel sorry for our general practice colleagues because they're inundated with so many things. They've got to look after the whole body top to toe. My knowledge of everything top to toe is pretty limited, and I've forgotten loads since medical school. So I rate them highly for being able to remember that. But I think it is hard for them. I mean, I see women, because I also specialize in, postpartum difficulties, and women are seen, and I remember doing the research on this, women are seen at the 6-week checkup by GPs, but the poor GP is, completely overwhelmed. So their focus is purely on the baby. They check on the baby, they ask women quickly, are you all right? And that's it, she's out the door. Baby is checked and, and they're happy because most women at that stage really just want their baby to be all right and are very selfless at that stage and don't really bother about themselves so much. Because they're probably sleep deprived as well, the poor thing. Whereas reality is you need to focus on them and ask them the questions, how are you faring? How is your sleep? How's your pelvic floor? How are things going currently? Are you leaking when you're coughing, sneezing? Are you rushing to the toilet? Are you having these problems? And a lot of women do have these problems, but they assume that actually it's okay, it's what's expected, it's what's normal, let's not talk about it. In fairness, the GP does want to know. The poor things haven't got time to ask the question properly. and there are so many things we can do to make it better. So I think it could be slightly better. And I think they should have tried slightly a lower threshold to send patients in, but also they need to be educated to ask the questions specifically. And after doing the research in King's, we made sure that our GP population were involved in creating our questionnaires and reiterate the importance of doing so. In my current hospital, St. Peters, I'll be doing the exact same thing and trying to educate by getting out there. And I think it's working. And also it's really educating the women as well to say, this isn't normal. For a short term, fair enough, your pelvic floor is remodeling, there's not much we can do. But after you stop breastfeeding, you've been doing exercises, you shouldn't be having this, and we should be able to do something for you. So please do come forward and we will try.
Okay, and just a quick one to finish off. Is incontinence mostly prevalent in older women and women who have given birth, or do you also see young nulliparous women in your practice? And if so, why is that?
So yeah, well, as you know, urinary incontinence has those two sides, stress and urgency. And of that urgency incontinence, you don't need to have had children to have had that. And actually, you get a peak of young ladies, and by young, I mean literally teenagers who are coming in with urgency urinary incontinence and decreased activity. And that could be just due to the bladder misbehaving, but it could be due to underlying neurological problems, so multiple sclerosis, undiagnosed spina bifida occulta, things like that can also cause those problems. So yeah, I get women across the whole ballpark of age groups. Yes, stress incontinence happens in two peaks. So postpartum women, and then after the age of 50, where actually the pelvic floor start to atrophy and the muscles aren't as strong as they were, and then it develops too. But yeah, there are two peaks, and similarly with urinary urgency, you've got the younger generation and the slightly older generation. But I get women across the board. Yeah.
Okay, we'll finish there. And sorry to everybody whose question we didn't ask, but I thank you so much, Mr. Thiagamoorthy, for a lovely talk and lovely discussion there. We'll move on to our next speaker, Miss